I am doing my pain medicine fellowship under the kind supervision of Dr. Syed Mahmood Ali at Sheikh Zayed Hospital, Lahore. Today's presentation will provide a comprehensive overview of cluster headache with a focus on recognition, pathophysiology, and the stepwise management for the pain physicians. We will proceed as follows. First, we understand what the disease is, then identify its triggers and risk factors. Then we apply, then we will apply the diagnostic criteria, reviewing the medical therapy, then ascending the interventional ladder, and finally some future directions. First, I will begin by presenting a case of a 40-year-old man presented for the worst eye pain of his life. He reports 3 weeks of being woken at 3 a.m. by severe, boring, right-sided pain behind his eye, lasting 60 minutes. His wife notes his right eye waters and turns red during attacks, and he paces the room relentlessly. He was initially diagnosed with migraine due to reported light sensitivity. Oral somatropin was prescribed, but without any relief. Neurological exam was normal. Later, we will discuss this scenario again and we will discuss its diagnosis and its management. So, it is one of the most painful conditions known to humanity, and the nickname suicide headache is not an exaggeration. The pain is so extreme and debilitating that it leads to the highest rates of suicide thoughts of any primary headache disorder. The burden of disease is so profound that it destroys careers, relationships, and mental health. There is 5 times increased risk of depression in these patients. Our first job as a physician is to recognize the severity of this condition and approach our patient with the urgency and empathy they deserve. So, who is affected? Cluster headache is a relatively rare disorder with a prevalence of about 0.1%. There is a clear male predominance with a ratio of approximately 3 is to 1. Though this gap is narrowing nowadays, maybe due to better diagnosis, onset is typically in the third or fourth decade of life, but can occur anywhere in life. Key risk factors for having an attack are male gender, having previous bouts of attacks, history of head trauma, and about 5 to 10% of patients has positive family history. This signals a genetic link. Now let's define the clinical picture. Cluster headache is a primary headache disorder, and it is the most common member of a group of disorders called the trigeminal autonomic cephalgias, or shortly TACs. The diagnosis rests on a classical triad of symptoms: pain, ipsilateral autonomic symptoms, and restlessness. First, the pain is exceptionally severe, sometimes described as 15 out of 10, strictly one-sided and focused round or behind the eye. Patients use very specific descriptors like a hot poker or a drilling sensation, which tells us about the intensity. Second, on the same side as the pain, we see autonomic signs such as lacrimation, conjunctival injection, ptosis, runny or blocked nose. Third point is, and this is the most important differentiator, is the patient's behavior. They experience an overwhelming sense of restlessness or agitation. They cannot lie down. They must pace, rock, or even hit their head against the wall. This is completely opposite to migraine patient who seeks stillness in a quiet and dark place. The attacks often have a circadian and circannual rhythm, frequently waking the patient at the same time each night and usually in the same season. There are two main types of cluster headaches. One is episodic cluster headache, second is chronic cluster headache. We distinguish between episodic and chronic forms based on the presence of remission periods. Episodic cluster headache features bouts separated by remission periods lasting at least 3 months, while chronic cluster headache is defined by the absence of such remissions for over 1 year, representing a more treatment-resistant phenotype. Finally, we have a subtype of chronic cluster headache called medically intractable chronic cluster headache, and this is formally defined by the failure of adequate trials of at least four preventive drug classes. These patients become candidates for advanced interventional therapies. So, what triggers the attack? So, during an active bout, patients are susceptible to specific triggers, such as vasodilators like alcohol, nitrates, histamines are potent precipitants of attacks. Strong smells, hypoxia, such as during sleep, are also common triggers. Anything that disrupts the sleep wake cycle, such as taking naps, having an irregular sleep schedule, or travel across time zones, heat exposure like a hot day or a hot bath can also set off an attack. Triggers are typically inactive during remission periods. One of the most important things we can do for our patient is to counsel them on triggers. Now we will discuss the formal criteria by International Headache Society, ICHD3. Remember, the diagnosis of cluster headache is mostly clinical on the basis of exam. An easy way to remember this is the 5-15-15-5 rule. This means the patient must have at least 5 attacks of severe, strictly unilateral, orbital, supraorbital, or temporal pain of 15 by 10 intensity, lasting between 15 minutes to 3 hours, with a frequency from 1 every other day to 8 times a day. Critically, each attack must be accompanied by either ipsilateral autonomic signs like a red, watery eye, or the cardinal signs of restlessness. Oh, okay. Now, how to differentiate cluster headache from other unilateral headaches? This table highlights the key differentiating features. Remember, accurate diagnosis is critical because treatment differs significantly. Starting with first and most similar form from the tag family, the paroxysmal hemicrania. Compared to cluster headache, the attacks are shorter, between 2 to 30 minutes, and another key thing of TH is its absolute response to a therapeutic trial of indomethacin. If indomethacin trial doesn't comply completely about the attacks, it is not paroxysmal hemicrania. In sunk and sona, attacks are incredibly short, only seconds to a few minutes, and they can occur dozens or even hundreds of times per day. This ultra short duration is the key clue. Hemicrania continua is unique. The patient has a continuous underlying headache of moderate intensity. The autonomic symptoms only appear during more severe exacerbations. Like in paroxysmal hemicrania, it also has an absolute response to indomethacin. Now, comparing to migraine, which is the most common source of confusion, the fundamental difference lies in the associated symptoms and patient behavior. Migraine is defined by nausea, photophobia, and phonophobia mostly, and the patient seeks dark, quiet places to lie down. This is in stark contrast. The cluster headache patient is restless and agitated, unable to lie still. Additionally, migraine attacks typically last 4 hours to 3 days, which is much longer than a cluster attack. And lastly, there is another condition called trigeminal neuralgia. This is easily recognizable. With its lightning bolt, electric shock like pain, the attacks are extremely brief, lasting only seconds, and are often triggered by light touch. chewing, or tucking. Crucially, there are no autonomic symptoms in trigeminal neuralgia. This is a graph comparing duration of attacks and different features of cluster headache versus migraine. Cluster headache attacks are short compared to migraine, but as you know, pre and post-DOM features may overlap. Now moving on to secondary causes of headache that can mimic the cluster attack, and we have to rule out those mimics. Fortunately, we have some red flags to remind us to do further investigations. Major red flags include any abnormal neurological exam, a sudden thunderclap onset, new onset after the age of 50, or an atypical presentation or course of disease. The decision to image is straightforward. Image the patient, every patient, when you have any red flag. Image when you have any red flag. Or sometimes we can image for our reassurance and the reassurance of the patients so that we are sure that we are not missing any serious pathology. So what we need to rule out? We need to rule out pituitary tumors. Pituitary tumors, brain aneurysm, carotid artery dissections in the neck, or other problem in the cavernous sinus area behind the eye. So investigation of choice is an MRI with pituitary protocol. Is the study of choice to look for structural lesions in the cellar and paracellar region that can mimic cluster headache perfectly. Now we will briefly review the pathophysiology of cluster headache and its clinical relevance. This is important because it helps us to find new and targeted therapies. While the exact cause and initial trigger is not well understood, but the prevailing model is T-system dysfunction. First system is a dysregulated hypothalamus, which is the brain's master clock. This initiates the attack, explaining their circadian timing. Clinical elements of this is in therapies like deep brain stimulation, which works on this area. This dysregulated hypothalamus then triggers the trigeminal system, releasing key mediators like CGRP and PSEA, PCAP. This system and neuropeptides are primary drivers of pain, vasodilation, and inflammation. Clinical relevance of this is these neuropeptides are the targets for some existing and emerging therapies. Verapamil, triptans, CGRP, monoclonal antibodies works on this system. Finally, this pain activates a hardwired reflex. The trigeminal signal stimulates the facial nerve via sphenopalatine ganglia, causing the parasympathetic symptoms like tearing, redness, and congestion, all on the same side. This is the where sphenopalatine ganglia related interventions works. In summary, a faulty clock activates a pain nerve, releasing neuropeptides, which triggers an autonomic reflex. So now we will discuss treatment options for cluster headache. Our entire treatment strategy for cluster headache is built upon three pillars. These frameworks help us address the disease at different stages. First, we have abortive therapy. Second, transitional or bridging therapy. Third is the preventive therapy. In abortive therapy, this is for stopping an individual attack after it has already started. Our goal here is speed and efficacy, using agents like high flow oxygen and subcutaneous somatriptan. In transitional therapy, this is used to break cycles during a severe bout or cluster period. It's a short-term bridge using interventions like a short steroid taper or a greater occipital nerve block to provide relief while preventive treatment begins to take effect. Preventive therapy, this is the cornerstone of the management, especially for chronic cluster headache. The goal is to reduce the overall frequency and severity of attacks over the long term. us in robotic therapy. For stopping an attack, for stopping an acute attack, we have two treatments with level A evidence. The first is high flow oxygen, and second is subcutaneous somatotropin. The patient must use a non-rebreather mask at a high flow rate of 12 to 15 liters per minute, and they must use it for a full 15 to 20 minutes. It is very effective, about 80% of the effect, and very safe. But we must be careful in patients of COPD. The second first-line treatment is subcutaneous somatotropin. A 6 milligram injection under the skin works very quickly. They can repeat it after 1 hour if needed, but the maximum dose is 12 milligram in a 24-hour period. The big contraindication is the heart disease. We cannot use in patients of ischemic heart disease or uncontrolled hypertension. Other first-line agents and options we have are: number one is non-invasive vagus nerve stimulation with gamma core device. This is an excellent non-drug option, great for patients who cannot use triptans. The patient applies it to the neck at attack onset. It has level B evidence and can be effective in aborting the attack. Then we can use intranasal triptans, a needle-free option but slower and less effective than the injection. Onset is around 30 minutes. Intranasal lidocaine can be used. It has level D evidence. It targets the sphenopalatine ganglion to reduce pain signals. It is useful as an add-on treatment. Second-line abortive therapies for refractory cases include dihydroergotamine, octreotide can be used, intranasal capsaicin, and in very severe cases, ketamine can also be used. But these agents have their own limitations and greater side effect profile. To break a bad cycle until preventive therapy begins to take effect, we use transitional therapies. A short course of oral corticosteroid, such as prednisone, at a dose of 1 milligram per kg per day for about 5 days, and then we taper it down slowly over the next week or two, can be very effective but has a high relapse rate after the taper. A much more effective and longer lasting option is greater occipital nerve block with local anesthetic and steroid. This is a simple first-line interventional procedure that can provide relief for weeks to months by modulating the pain centers in the brainstem. In refractory attacks, a second-line option is ergotamine, which we can use in as 1 to 2 mg per oral twice a day. It can be very effective, but there are serious side effects such as ergotism, so limits its use. Thirdly, we have for long-term prevention, our goal is universal. We aim for complete suppression of attacks as quickly as possible. Timing is critical but differs by type. For episodic cluster headache, we start preventive immediately at the onset of new cluster period. For chronic cluster headache, therapy is continuous and long-term. We must titrate aggressively in both cases, rapidly increasing the dose every 1 to 2 weeks to reach an effective level that breaks the cycle. Remember to always bridge with abortive and bridging therapies. Discontinuation is managed differently. In episodic cluster headache, after attack stops, we continue for 1 to 2 weeks, then begin a gradual taper. In chronic cluster headache, we continue the effective dose indefinitely, attempting a slower taper only after a sustained pain-free period of about 6 to 12 months. Our first choice of drug is verapamil in prevention. Verapamil is a gold standard for prevention. Its mode of action is not completely understood, but it is believed to act on hypothalamus and modulate neuronal activity in the hypothalamus by blocking calcium channels. This may stabilize the dysfunctional rhythm that triggers attacks. It may also inhibit neurogenic inflammation and vasodilation of cranial blood vessels responsible for acute attacks. More than 50% of patients achieve significant reduction of bouts. Those often need to be high, very high, between 480 to 960 milligram per day to achieve efficacy. We increase dose by 80 milligrams every 10 to 14 days. For this, ECG monitoring is mandatory to look for PR interval prolongation before initiation and before each dose increase to prevent heart block. For patients with episodic cluster headache, we have a CGRP monoclonal antibody called glecanezumab offering a targeted treatment option. About 40 to 50% of patients achieve at least a 50% reduction in attacks frequency. It is administered as a 300 milligram subcutaneous injection once a month. This medication is specifically FDA approved for episodic cluster headache and represent an important advancement in our ability to directly target the CGRP pathway involved in cluster attacks. When verapamil is not enough or cannot be tolerated, we have other options like lithium carbonate is an old but effective second line option. We start at a 300 mg twice daily and titrate to a blood level of zero point 0.7 to 1.2 milliequivalents per liter. This requires a regular monitoring of kidney function and thyroid level due to its potential side effects. Topiramate is another option we sometimes use, but we must start low and go slow to avoid cognitive side effects like brain fog. Finally, melatonin at a high dose of 10 to 15 milligram at night is sometimes used based on the theory of circadian rhythm dysfunction. It can be helpful as adjunctive therapy, but the evidence for it is weaker. Methylphenidate, a historical agent we rarely use nowadays. Gabapentin, a pregabalin. These are used anecdotally, particularly if there is a neuropathic pain component. Dose needed to be high, but benefits are often modest. Just a quick note on use of indomethacin and NSAIDs and opioids. Remember, indomethacin is not a instead, treatment for cluster headache. Instead, a trial of 150 to 200 mg per day is used as a diagnostic test. An absolute complete response to indomethacin is required criteria to diagnose its mimics such as paroxysmal hemicrania. Secondly, it is critical to avoid routine use of NSAIDs and opioids in cluster headache management as they are largely ineffective and carry a significant risk factor profile, and there is significant risk of medication overuse headache, complicating the patient's condition further. Management in pregnancy requires a careful risk-benefit analysis, favoring non-pharmacological and interventional options like nerve blocks, where possible to avoid potential teratogenic effects of medications. For abortive therapy, high flow oxygen is the first choice and is absolutely safe. Somatriptan can be considered as a second choice. There is no clear evidence that it causes birth defects, but ergotamines must absolutely be avoided. For transitional therapy, greater occipital nerve block with just local anesthetic and without steroid is an excellent option to avoid exposing the baby to repeated courses of oral steroids. For prevention, verapamil is considered relatively safe to use. However, we must avoid lithium and topiramate as both can cause birth defects. So, for status like refractory attacks, start with aggressive oxygen and triptans. Next, add IV dexamethasone for anti-inflammatory effect and metoclopramide for nausea and analgesia. If these fail, admit for continuous IV infusion. Dihydroergotamine is effective, but check for cardiovascular disease contraindication. Valproic acid and lidocaine are alternative infusions that require monitoring. The goal here is to break the cycle and transition back to outpatient prevention. This is a quick reference guide for aborting attacks. Start with oxygen and injectable somatriptan. For bridging, a nerve block is your best fast option. For long-term prevention, start with verapamil, but remember to check ECGs. The other agents are for when these first choices are not enough. So, we case about the case we discussed earlier, diagnosis was episodic cluster headache. Why? It is unilateral pain with autonomic signs plus agitation and circadian pattern. So, corrected therapy should be high flow oxygen and subcutaneous somatriptan, not oral somatriptan. Oral somatriptan cannot help these patients because oral somatriptan effect of oral somatriptan can take very long. And preventive strategy, Verapamil titerated to efficacy. Key learning point here is agitation and circadian timing distinguish it from migraine. Speed of abortive therapy is critical. Now we move on to the core interventional management for patients who have failed maximum medical therapy card, MICCH. The field has moved away from the destructive ablative procedures that carry permanent side effects toward the neuromodulation. Using electrical stimulation, sorry, using electrical stimulation to modulate the activity of nervous system structures without destroying them. There is stepwise ladder approach. We start with simple low-risk peripheral nerve blocks, then move to the procedure targeting the spinopalatal ganglia. For more refractory cases, we consider implantable peripheral nerve stimulators. Finally, for the most extreme cases, we have central neuromodulation with deep brain stimulation. So now, greater occipital nerve block is a very familiar procedure for you, all of you. The target is greater occipital nerve as it traverses the superior knuckle line. The traditional landmark is about a third of the way from the external occipital protuberance to the mastoid process. Ultrasound guidance is highly recommended due to safety. We often look for paresthesia radiating to the scalp to confirm the placement. We inject a combination of long-acting local anesthetics like bupivacaine for immediate diagnostic effect and steroid for longer-lasting therapeutic effect. While its primary role is as a bridging therapy, it can also be used as a repeated preventive measure in chronic patients. Well-conducted studies shows that over half of the patients experience a significant reduction in attack frequency. Moving on to non-invasive neuromodulation. We have a handheld device called gamma. It is placed on the neck over the vagus nerve and delivers a mild electrical current through the skin to stimulate the nerve. It is thought to work by activating the nucleus tractus solitarius in the brainstem, which has connection, thereby modulating the entire headache pathway. It can or preventively it can be used twice a day. The clinical evidence shows it is most effective for stopping acute attacks in patients with episodic form of the disease. Its biggest advantage is that it is completely non-invasive and very safe with only minor side effects like irritation. Am I audible? Hello?
जी जी।
Okay. The sphenopalatine ganglia is a key structure located deep in the pterygopalatine fossa behind the maxillary sinus. As the main parasympathetic ganglia, it is the final common pathway responsible for generating the autonomic symptoms of cluster headache. The rationale for targeting it is clear. If we can block or modulate its activity, we can directly reduce hearing, redness, and nasal congestion going back to the brain. It can be approached several ways. A simple transnasal approach using a cotton tip applicator soaked with the local anesthetic can provide short-term relief and also a good diagnostic test. For a more prolonged effect, we use the percutaneous approach, guiding a needle under fluoroscopy either above or below the zygomatic arch to assess the pterygopalatine fossa. Moving on to sphenopalatine ganglion neuromodulation, we can either do pulse neuromodulation with pulse radiofrequency and ablation. Both pulse radiofrequency and radiofrequency ablation target the sphenopalatine ganglia, but through different mechanisms. Pulse radiofrequency uses electrical pulses to modulate nerve function without destroying tissue. It is safer. It is safer with no risk of permanent numbness. Sorry. RFA uses heat to create a controlled permanent facial numbness and bleeding. Pulse radio frequency is generally preferred first line due to its safety advantage, while radio frequency ablation remains an option for selected cases where longer duration is needed. Palatine ganglion stimulation, although not currently available, SPG microstimulation is a brilliant proof of concept therapy. A microstimulation device can be implanted in pterygopalatine fossa. This allows patients to avoid attacks by stimulating the SPG directly via remote control to activate it at the attack onset. It is highly effective as an abortive therapy. It demonstrates that modulating this ganglia can effectively halt attacks, informing future device development. Occipital nerve stimulation involves the surgical implantation of electrodes in the subcutaneous tissue over the occipital nerve. These electrodes are connected via wires to implantable pulse generator, which is usually placed in the buttocks or abdomen. It is primarily preventive therapy for MICCH. Landmark ICON trial shows over 50% of patients achieving a significant reduction in attack frequency. Occipital nerve stimulation has high complication rates such as lead migration, most common more than 50%, infection, battery depletion, pain over the side. Finally, we have a last resort option, deep brain stimulation. Deep brain stimulation of the posterior hypothalamus is a last resort intervention for the most refractory cases after the ONS failure. While open label studies show the 60 to 80% response rate, it carries a small but serious risk of intracerebral hemorrhage, infection, and hardware problems. This is performed only in highly specialized centers. Let's put this all together with a real case. A 45-year-old man with a chronic cluster headache has failed high-dose verapamil, lithium topiramate, and glucanizumab. He meets the criteria for MICCH. Our first step was a series of greater occipital nerve blocks. They worked well, but the effect only lasted a few weeks. So we stepped up to sphenopalatine ganglia pulse radiofrequency procedure. This gave him a 60% reduction in attacks for a good 6 months. Unfortunately, the attacks slowly came back. We then referred him for an occipital nerve stimulator. After it was implanted, it took a few months to work, but he eventually achieved over a 75% reduction in attacks. This is a fantastic result. However, a year later, the lead migrated and he needed a revision surgery to reposition it. This case shows the entire ladder in action, the progression of treatment, the success, and the very real management of complications. Effective patient counseling and education is vital. First, reassure that it is not a tumor and you are not crazy. It is a known neurological condition. Second, we should give clear instruction about triggers, such as completely. It is a granted trigger. Third, your oxygen cylinder ready at home and your somatropin injector with you at all times. Finally, and most importantly, we give them hope. We say this is a terrible disease, but we have a very clear plan. We have a ladder of many options. If one thing doesn't work, we move to next. We will not give up until we find something that helps you. This will build trust and compliance to treatment. So we cannot manage these complex patients alone. It requires a team. As a pain physician, we can lead the team, making the diagnosis, managing the medication, and performing nerve blocks. We work closely with neurosurgeons who implant the advanced stimulator devices. It is absolutely mandatory to have a psychiatrist or psychologist on the team to screen for and treat the depression, anxiety, and suicidal thoughts that are so common in these patients. For complex procedures, an interventional radiologist can help with precise image guidance, and we should encourage our patients to connect with patient sports groups like them, which provide invaluable community coping strategies and advocacy. Okay. We should set realistic expectations for patients. This is often a lifelong condition, though its expression can change over time. Studies shows that about 13% of patients with episodic form will eventually transit to chronic form. On a more positive note, about a third of patients with chronic cluster headache may see their disease revert back to the episodic form. Complete remission, sometimes called burnout, where a patient has no attacks for over 3 years, is relatively rare, occurring in only about 10% of patients. This underscores the need for effective long-term management strategies. The future is bright with ongoing emerging treatments, including new CGRP monoclonal antibodies for chronic cluster headache, PCAP targeted therapies, and next generation neuromodulation devices with improved safety profiles, offering hope for better management. In conclusion, cluster headache is a severe but distinct disorder. Our approach must be systematic, diagnosis confidently using ICD-10 criteria, treat acute attacks aggressively with oxygen and triptans, start preventive therapy with verapamil. For refractory cases, we have a clear interventional ladder, starting with low-risk nerve blocks and moving to neuromodulation. Throughout the journey, our role is to manage the whole patient, addressing triggers, providing education, and vigilantly screening for the devastating psychiatric comorbidities that accompany this disease. Okay, finally, if you remember nothing else from this talk, please remember these six clinical pearls. First, you should have high degree of suspicion with if a patient present with a typical history of unilateral headache with autonomic symptoms. Number two, order
I think there is some network issue. He is rejoining.
sorry, helpers. Number four, you must check an ECG before starting Rapamil and before every single dose increase. Number five, your first and best intervention procedure is a greater occipital nerve block. And finally, number six, you must screen every single cluster headache patient for suicide risk at every visit. This is a critical part of their care. This is my slide for references. Thank you very much for the complex with the scientific approach we can make a profound difference in the lives of our patient. Thank you.
Thank you so much, Dr. Abdul Hanan, for such comprehensive talk. Now it's time for question and answer session. If you want to ask any question, audience, you can unmute yourself and ask, or you can drop your question in the chat box. Any question from audience side? So I think you have covered the topic in a comprehensive way. So there are no questions. So thank you everyone who joined us today, and we will have our next session next month, inshallah. And we look forward for your active participation in future sessions. Thank you.